What do you think are the biggest challenges facing the NHS? It sounds like a straightforward NHS consultant interview question until you actually try to answer it. Workforce shortages, waiting lists, burnout, training, productivity, financial pressure, poor IT, staff retention. Where do you even start? And perhaps more importantly, how do you structure an answer to a question like that without sounding exactly like every other candidate who sat outside that interview room? My name is Dr. Pranav Kukreja. I am a consultant anaesthetist and a clinical director of an anesthetic department. I interview candidates for consultant jobs, and in these videos, I'm going to try and help you not just give the panel a credible answer, but also to develop your own thinking about wider issues, which you'll be dealing with once you do get your consultant post. So in this episode, I'll use two recently published national reports to answer some of these questions. There's 4 questions that we'll go through. I'll first talk about what the reports say about them, and then my own thoughts on how those questions should be answered. So if you're preparing for an NHS consultant interview in 2026, there are 2 reports that I think are particularly useful. The first is the GMC's Workplace Experiences 2026 report, which looks across the medical profession at what it's actually like to work in the UK as a doctor at the moment. The second is the Royal College of Anaesthetists State of the Nation 2026 report. And this report actually it came up in an interview in an ICU consultant interview recently and is quite relevant. Now, obviously, I'm an anaesthetist, so the second report is particularly relevant to my specialty, but if you're a surgeon, a physician, a radiologist, emergency physician, psychiatrist, obstetrician, or from any other specialty, don't switch off, because this isn't going to be a 40-minute summary of those 2 reports. You can read the reports yourself, but instead, I'm going to try and help you answer some of the questions you could actually face at a consultant interview and how you can use these reports to give a bit of structure and credibility to your answer. So questions like, what are the biggest challenges facing the NHS? How would you improve staff well-being? How would you maintain the quality of medical training when the service is under pressure? Why do we have a medical workforce shortage when thousands of doctors are unemployed? How can consultants improve NHS productivity? And perhaps the most important question of all, how can you, or what can you as an individual consultant realistically do anything about any of this? Because simply knowing the numbers won't be enough. You can memorize that X percentage of doctors are burnt out, or that we're short of X thousand doctors. So can everybody else. If your answer is just a sequence of statistics that you've learned the night before, you're demonstrating that you can read a report. You're not necessarily demonstrating that you can think like a consultant and you understand what the report's actually trying to say. So what I want you to do is to take the evidence and ask, what does this actually mean? What does it mean for patients? What does it mean for the service? What does it mean for the people working for it? And crucially, what does it mean for the department that I'm applying to join? Now, you don't need to have an opinion about every page of the report. In fact, I think that's another mistake. But you should know a little bit about everything, because you don't know what the interview panel is going to take you up on. There are 1 or 2 things that you genuinely should care about within the report, and I think those are the things that you should do a deep dive on. Maybe that's training, maybe it's staff well-being, elective recovery, productivity, digital transformation, perioperative medicine, workforce retention. They are all problems which these reports talk about in their different parts. But the main point is to understand what they are trying to say, and then have something intelligent to say about it yourself. So form an opinion on it, because that's where you stop sounding like someone who's prepared for an interview and you start sounding like someone that the panel can imagine appointing as a consultant and join them in that trust. So let's take some of those questions. Question number 1, what are the biggest workforce challenges facing the NHS? Now, let's start with the GMC Workplace Experiences 2026 report. I don't think the headline is simply that doctors are unhappy. In fact, that's not quite what the data shows. After the very difficult pandemic period, doctors' workplace experiences had actually started to improve. There were significant signs of improvement in 2023 and then in 24, until we hit 2025, where that progress seems to have stalled. The overall satisfaction fell slightly, and the GMC's concern is that some of these developments or improvements we've begun to see may be going into reverse. Now, that's a useful context, because there's 1 number from this report which I think is very important, and that number is 41%. Now, 41% equates to roughly 4 in 10 doctors. 4 in 10 doctors in the UK say that at least once a week they find it difficult to provide a patient with sufficient level of care that the patient needs. So think about that for a moment. They haven't asked, are you busy? They haven't asked, are you stressed? Not even, are you satisfied with your job? The question essentially is whether you can provide your patient with the level of care you think that they need. And 2 in 5 doctors, surprisingly or sadly, say that they struggle to do that at least on a weekly basis. For GPs, it's even worse. It's 60%. Why? What's this about? So the GMC went back to ask the doctors what they actually meant by sufficient care, and the expectations weren't particularly extravagant. The doctors described good care as timely, patient-centered care considering the needs of the whole patient. And the report's argument is that the working conditions sometimes make even that quite difficult. There are delays, staffing problems, workload pressures, increasing complexity of patients, and problems with coordination between different parts of the NHS, between primary care and secondary care, for example, and between specialties. And only 20% of doctors thought that the primary secondary care coordination was effective. That's a really low number. Delays in care were because of screening being a barrier to providing good care. So there's a clear argument here. The environment in which the doctors work affects the care that they're able to provide. But there's a caveat here. And the caveat is that this does not mean that you're externalizing the responsibility or the doctors surveyed are externalizing their responsibility. We as doctors, we're responsible for our decisions. But when you become a consultant, that responsibility becomes even greater. You can't simply say that the system was busy or that we were understaffed and, well, that's just the NHS. No, that's not the sort of things that you say. Those things may explain the environment in which the decision was made, but they don't automatically excuse the decision. And that's important for the interview because you need to be capable of holding these two ideas simultaneously. The fact that I'm accountable for the decisions I make, but also that the quality and reliability of healthcare is influenced by the system in which I work and the system in which those decisions are made. They're not contradictory positions. It's part of being a consultant. Because if you repeatedly see good people struggling with the same problem, eventually you have to ask whether there's something about the way the work is organized that needs changing. So coming back to the question, what are the biggest workforce challenges facing the NHS? Now, I've described one part of the workforce problem. It's not simply that we don't have enough doctors. It's also the environment in which the doctors we already have are being asked to work, and whether that environment allows them to do the job properly. There's other aspects to it, which we'll come on to later on in the episode. One of the issues is about retention. There's doctors starting to think about leaving the NHS. Experienced consultants are retiring earlier than they would. Doctors reducing their hours because working more no longer feels worthwhile. Younger doctors looking at prospects in the UK and deciding that they'd rather work abroad. And then there's the whole training and progression issue. What happens when we say we need more doctors, but thousands of doctors who actually want to progress can't get into training posts? So if I was answering that question at an interview, I wouldn't reduce it to a single issue. I'd probably frame it around 3 connected problems. 1, do we have enough people? 2, are we retaining and developing the people we've already got? And the 3rd, are we creating a working environment in which those people can actually do their jobs effectively? Those 3 things feed into each other. And that's why I think that figure of 41% or 2 in 5 is so important. It tells us something about that 3rd problem, that even if you solve the numbers on a workforce spreadsheet, you haven't necessarily solved the workforce problem itself, because the guys who are there are not working in the best of conditions. If the people you've recruited are working in an environment where they struggle to deliver the care that they believe patients need, you're likely to end up back at the retention, burnout, and ultimately workforce capacity. Now we'll come back to the other 2 parts, the training bit and the retention bit, as we go through the reports. But that leads very naturally on to another interview question, which is, how would you improve staff well-being in your department? Now, well-being is such a term, isn't it? How do you even say something concrete around well-being without sounding too fluffy? Well, we can use the GMC report to answer this question. The report says that when doctors repeatedly feel unable to provide the standard of care that they believe their patients need, the consequences aren't purely just operational. The GMC survey found that doctors described frustration, loss of professional fulfillment, and in some cases, even moral injury. And I think that's quite important because the tendency is to put all of this under the broad heading of well being. And then the solution becomes, how do we make the doctors more resilient? Do we need mindfulness? Do we need well-being sessions? And those things may have a place, but if somebody is distressed because every day they're trying to deliver good care in a system that makes doing anything so difficult, perhaps the first question shouldn't be, how do we make this person more resilient? Perhaps it should be, what is making their job unnecessarily difficult? So if I'm answering this at an interview, I wouldn't immediately start listing well-being initiatives. I'd start by diagnosing the problems about where is the unhappiness coming from? Is it workload? Is it the rota? Is it poor team behavior, lack of autonomy, poor progression of the career, poor IT systems even? You pick your example, and by that I mean, what can you talk about best? There's potentially a vicious cycle here because the working environment makes it harder to provide good care. Professional satisfaction falls, the burnout increases, some doctors reduce hours, some consider leaving, some move abroad, and therefore the workforce capability just falls. Pressure on those who remain, it increases, and round you go. So those few people who are left just have to deal with more and more. The GMC also describes the converse of this as a virtuous cycle, where they say that better workplace experience, greater satisfaction, more sustainable workforce. So workforce isn't simply how many doctors we employ. It's also how effectively do we retain and use the doctors that we've already got. There's a much stronger answer to that well-being question than simply saying that you'd introduce another well-being initiative. But again, let's come back to this actual interview question. How would you improve staff well-being in your department? Because recognizing the problem isn't enough. The panel wants to know, what would you actually do about it? And I think the GMC reports helps us here because it stops you reaching immediately for a generic solution. You start by understanding what is actually driving poor well-being in that particular department. And hopefully you've already started doing that well before you walk into the interview, because you will have spoken to several people at your pre-interview visits, the consultants, trainees, SAS doctors, speaking to the clinical director, speaking to the medical director, the service managers. Ask people what works well, what makes their working lives unnecessarily difficult. Explore both sides of the spectrum, because you may discover that well-being isn't really the problem. The problem may just be the fact that it's a very unpredictable rota, and the way people work, there might be late finishes every day, processes might be inefficient, and those inefficient processes create unnecessary work. Pre-op assessment, for example, is a classic and is usually a problem in a lot of hospitals where one arm doesn't speak to the other, for example, and information doesn't get conveyed from the pre-op assessment department on to regular people who do the list, and there's a breakdown of communication. It might be difficult relationships within the teams, or perhaps there's very little options for, let's say, SAS or locally employed doctors to progress. SAS and locally employed doctors they feature quite heavily in the GMC reports as well as a group of people who find career progression extremely difficult. So these are potentially well-being interventions. Fixing a dysfunctional process that frustrates people every day may considerably improve the well-being far more than organizing another well-being afternoon. So at interview, I just narrow it down. You don't need to promise to transform the entire department. Identify one or two things you've discovered that you could realistically be involved with, and explain what you could do. Any of the things that we've spoken about before. And there's another opportunity where candidates miss out. This is your time to link it back to something that you've already done in the past. You might have worked on, first of all, link it to the problem you've seen. So say that during your pre-interview visit, you found XYZ. And in my past life, in my last placement, these are the initiatives that I did because there was a similar problem. And using that example from the past, say that you could bring that to this trust and you could implement it here to maybe bring about changes and improve the lives of people. And that is how you improve staff well-being. You're giving them something much more concrete, and you're answering that question at a consultant level. You've now used the GMC report to understand the wider problem. So there's a bit of a framework that you can use for a lot of these questions. And the framework is that you've relied on national evidence, you've found a local problem speaking to the people at the trust, you've mixed that with your own experiences in the past, and you are proposing some realistic action to improve the lives of the people who you're going to be joining. And that's how you turn the knowledge of a report into an answer that's actually about why they should appoint you. Let's move on to the next question. How would you maintain the quality of medical training when trainers are under increasingly high service pressures? Now, this is particularly relevant if you're applying not just for a consultant post, but if your role has some kind of educational element to it. And even later on in your career, perhaps if you've applied to be college tutor or you're applying to be training program director. And the GMC report identifies an important problem here. We often talk about training capacity in terms of the number of trainees and training posts. But you also need the trainers with sufficient time and capacity to train them. The GMC found that those specialists who are registered on the specialist register as trainers were under greater pressure than those who weren't. So there was a high risk of burnout, 20% amongst the trainers compared to 12% who weren't trainers. And about a fifth of the specialist trainers said that they'd stopped or reduced their training or supervisory work because of workload pressures. So the GMC's recommendations are quite practical. They talk about protecting time for training, providing structured support for trainers, recognizing their contribution, and strengthening educational governance. So imagine the panel asks, how would you maintain the quality of training when the trainers themselves are under so much of service pressure? Quoting the burnout statistic won't get you very far. That may be a starting point, but the first priority is to protect the time that already exists for training. If somebody has educational supervision, teaching, or training program responsibilities in their job plan, that time shouldn't routinely disappear because the clinical service is busy. There will obviously be exceptional circumstances, but if educational is constantly the first thing that gets sacrificed, effectively, it's not protected time at all, is it? Second, measuring whether training is actually happening. Now, don't assume that because educational time appears in a job plan, trainees are receiving it, or if trainees are timetabled to go to teaching, for example, there shouldn't be an assumption that is happening. You can look at the trainee feedback from the GMC surveys. Things like, are supervision meetings happening? Are the trainees getting their learning opportunities? The GMC training survey, which I mentioned, is quite a useful one to look for that. And if there is a problem in one particular area, or a group of a subspecialty within the department, then maybe focus on that. And finally, the GMC report also talks about not overloading the same enthusiastic trainers, because it's very easy for the good trainers to acquire more trainees, more educational roles, sit on ARCPs, get involved with simulation, add project after project. Instead, they suggest developing a broader faculty and bringing new trainers in to support them. Now, you could be one of those trainers, or you could talk about something that you've seen at another hospital. So how would you maintain the quality of training when trainers are under increasing service pressure? You can't simply say that I would protect training time. What can you actually do? And again, this is where your preparation before the interview matters, because if you're applying for a college tutor role, you won't directly apply for a college tutor role. That'd be quite unusual. But if there's any educational component to your job, then do look at the trainee survey for that hospital for the last year. But also, when you go on your pre-interview visits, speak to trainees and the trainers and find out where the actual pressure points are. And then choose one or two things within your sphere of influence. And after you've chosen that area, tailor it to what you have done in the past, because it's another good opportunity to show the panel that you've maybe run teaching programs in the past or developed simulation, been an educational supervisor of some description, improved access to training to a certain group of doctors, things like that. And that's where you can talk about it. So again, your answer develops a very clear structure. You looked for the evidence, you've identified the local problem, you've targeted some intervention, and then you join that with your own experience to talk about it. Most importantly, don't promise the panel that you're going to somehow protect all training from NHS service pressures. That's just unrealistic. It's not going to happen. And half the people in the panel will not like you. The other half will think you're too naive. So please don't give them any absolute answers because it's just not possible. You want to show the panel that you know how to identify the problem, you know where you could intervene. Question number 4. Why does the NHS have a doctor shortage when doctors can't get training posts? Now, this can also be asked in many other ways. What are the current challenges around medical training and workforce planning? And can be part of your answer to question 1, where they ask you what the major challenges facing the medical workforce in the NHS are. And this question was recently asked at an interview. What can be done to improve recruitment and retention of doctors in the NHS? To a candidate who had previously worked in that trust. So the expectation was that he would know what's going on in there and be able to give them a credible answer. So we know that it's fair game. It gets asked. You can wing it, but if you ground it in some evidence, it comes across as a lot more credible. It's one of the strangest aspects of the current workforce debate, which is the fact that, and even the GMC identifies these significant concerns among early career doctors about career progression. So, among doctors in training, 43% disagreed that they were able to progress their career in the way they wanted, and three-quarters of those identified competition for training posts as a barrier. This was really bad amongst foundation doctors who just disagreed with the fact that they could progress their careers in the way that they wanted. Locally employed doctors, as I mentioned earlier, they are another particularly interesting group. Their satisfaction actually fell from about 63% to 54% in a single year, and a quarter of them were at high risk of burnout. And they were more likely than doctors overall to say that leaving UK medicine permanently or moving abroad was a likely career move. So we arrive at this slightly strange situation. We're constantly talking about medical workforce shortages, but at the same time, large numbers of doctors are saying, I can't progress. And some of them are considering leaving. Now, keep that thought in mind because the Royal College of Anaesthetists report gives us a remarkable worked example of exactly this problem. Now, anesthesia has a substantial workforce shortage, and yet at the same time, there are doctors who want to train in anesthesia, but they cannot obtain training posts. So the problem isn't simply that we don't have enough doctors, it is that workforce need, the training capacity, career progression, they're not necessarily aligned with each other. And that distinction is important in an interview because you can use it quite well to your advantage. If you're asked what can be done to improve recruitment and retention, it is very easy to give a national policy answer to say, well, we need an increase in training numbers, improved workforce planning, expand the capacity, improve working conditions, etc., etc. They're all perfectly reasonable answers. But again, I ask, what is it that you can do? And if I'm answering this as a consultant, I'd bring it back to the people already working in my organization. Take locally employed doctors, for example. If I've got a clinical fellow who wants to progress, I may not be able to create an ST4 number for them, but I can make sure their job isn't simply filling gaps on the rota. I can give them meaningful educational supervision and I can help them identify what they need for their next application. I can make sure they have access to teaching, audits, quality and improvement, and simulation, and I can involve them in departmental projects. So it helps them build credible material for their interviews and for their CVs. And I can have an honest career conversation with them rather than waiting until they're frustrated enough to leave. The same applies to trainees. I can't personally fix national competition ratios, but I can influence whether the department is somewhere people actually want to train and eventually want to come back to work as consultants. And if you are one of those people who's worked in that department and have come back to work there, well, say so. Well, they will already know that, but make some noise about it and say how good it has been and what you've found good that you've come back there. And retention doesn't begin when somebody hands in their resignation. I mean, by retention, meaning people leaving and going away, that's a bit of a problem as well. It starts much earlier than at the point of resignation, because it's about how people feel. Do they feel valued enough? Are they developing? Do they have any control over their working lives? Is there a credible future for them there? And that's where I'd make the answer personal. Bring in your own experiences. I've said this many times. Bring in your own experiences and what you have done in the past. You have the permission to personalize this answer or any answer and make it about you. It's your interview after all. So those are snippets from these two reports. And I don't want you to come away from this video thinking that you need to memorize all those numbers. I've tried to use as few numbers as possible. Just know a few important figures and know what the reports are saying. But most importantly, think about what they mean, because there's a pattern running through every question we've discussed. Whether the panel asks you about workforce, well-being, training, recruitment, all of those things, simply describing the national problem isn't enough. Well, it will be enough in the sense that, yes, you will be able to say something, but the problem is that you want to tell the panel what your thoughts are, what your opinion is, where you stand with whatever the report says. Do you have an opinion about it? You're being interviewed for a consultant job. So eventually the answer has to come back to, what does this mean for this organization? And the second question, what can you do about it? And that's why the framework we've kept coming back to is, I think, quite useful. National evidence, the local platform, realistic intervention, and then bring in your own experiences. You don't need to solve all of the NHS's problems. You won't be able to. But in fact, don't even try doing that, because, like I said, you'll come across as silly if you are naive enough to say that you can solve all the problems yourself. If you're asked about workforce crisis, you're not personally going to create thousands of training posts. Similarly, if you're asked about burnout, you're not going to fix every cause of poor staff well-being. And if you're asked about training pressures, you're not going to somehow make service pressures disappear. The panel knows that. What they want to know is whether you understand the bigger problem and whether you can work out which part of it you can influence, and whether you have the judgment and experience to actually do something useful. And that's where your own experience really comes in. You probably supervised somebody, changed a pathway, supported a struggling colleague, brainstorm all of these things before your actual interview and speak to somebody about it. Your experiences in the end tell the panel what kind of consultant they're appointing, and that ultimately is what the interview is all about. So if you're preparing for a consultant interview, subscribe to the channel, because I'll be working through more real consultant interview questions, recent reports on the kinds of answers that actually distinguish candidates. And if you know somebody preparing for an interview, send this episode to them. The next episode is going to be about how to make a presentation at your consultant interview, and I'll see you in the next one.